Well, thanks everyone. The dean of our medical school couldn't be here today, so we got the dean or quasi-dean from the University of Witwatersrand in South Africa to join us. But in all seriousness, Deb Basu is a physician who actually holds 3 hats at the University of Witwatersrand, in the medical school, in the business school, and the public health school there. And his talk today is going to focus on how to use information in management information in the South African context. What information and resources they have available, how are they thinking about using them, and then towards the end of this, to think about collaboration. We met with Eric last week, and the question was if they could they replicate things like the cardiovascular registries in South Africa using the same kind of data architecture? Can we then compare outcomes and process between South Africa and here? I think one of the exciting opportunities for us going forward is actually one of Deb's other responsibilities is he's one of 2 centers for the South African government to train hospital managers. So for all the hospitals in South Africa, he's already trained about 1/3 of the people in management. And so one of the things that he could potentially get to that we can't get to here is to think about quality and quality improvement, not just as a concept, as a research concept, but then actually begin to train management in these basic concepts and hold them accountable for improving quality. So that could be a huge opportunity and a huge experiment. I should say Deb's here actually as a visiting scholar funded by Johnson & Johnson, here being at Fuqua at the business school. And he's also was here most recently last November as a participant in a new effort between the Fuqua and the Global Health Institute looking at health management education in med schools, business schools, and public health schools around the world. And he's also been Duke's host in South Africa last summer. Actually, Fuqua and Witwatersrand ran a short course for people engaging in hospital management in South Africa. So, Deb, thanks for joining us, and look forward to your talk.
Thanks, Kevin, and thanks for giving me this opportunity to speak to you. When I'm preparing this presentation, I was a bit nervous in that sense to know that what is the audience. And as Kevin mentioned, that I use different hats, and like a chameleon, I change my presentation depending on the audience. So it's very easy when you have a grouped audience, but when you have a mixed audience, it's difficult to present. So please forgive me that if I don't address all the questions. So I'll talk through some of the things as I use my slides. It's an interesting time, actually. I'm in U.S., and when your health bill get passed on Sunday, and just by the way, we actually have exactly more or less same time, we have a new government in South Africa. We had a new president last year, and we also passed our health, comprehensive national health insurance, and it is coming into effect from 1st of April. So we are trying to beat you in that sense. And it was the whole set of challenges which you are going through now, we went through. But luckily, our opposition is not very strong. So the government, the ruling party, which actually started talking about national health insurance in early 90s, only in 2010 we started introducing it. So it took us 20 years to go through this process. And obviously we will have a lot of similarities. To bring in, 60% of our people who are not on health insurance into the health insurance, and it is the biggest challenge for us. So we are looking forward, and I think we will do some work on that basis. My talk, I think it's a bit provocative because we use the term epidemic normally for the infectious diseases. And I'm using this term very provocatively to see that, if this is a real issue. And I think this is a problem where we can think of some allocation of funding, and I'm going to use this as a challenge to show you some things. I belong to this university. This is established as a mining school in late 19th century, and in 1921 it was formulated as a university. It is now have 25,000 people and divided into similar type of schools what you have. And I belong to, as Kevin mentioned, to the School of Public Health, which you don't have. And obviously we have other appointments in the medical school as well as in the business school. I believe in this. I don't know how many. From Dahl actually talks about it's a capital mistake to theorize before you have the evidence and biases the judgment. And this is one of the philosophy I started believing in my life. Because throughout my life I was a clinician and I start practicing it, whatever is there. But when I look at it and I think this is the evidence which deceive you and what you think and what you believe, it changes. So I'll talk about some of the backgrounds about South Africa and the Gauteng state or province, which is equivalent of the state which you talk about. I'll talk about the burden of non-communicable diseases. And the reason I provocatively using non-communicable diseases because when people present usually about South Africa, they talk about HIV. And this is a myth which I try to break. And then we'll give you some examples to justify that why I believe this is a silent and neglected epidemic. And then I'll talk about some of the way forward. To make you understand, it is on the southern tip of Africa. We have 9 provinces or states, and we have 52 districts. So these are geographical area. And Gauteng, which is the smallest state in the South Africa, which has 6 districts and sitting in the middle of South Africa, in the northern part of South Africa. If you compare, we have a land area 1.4% of the whole of South Africa in Gauteng, but we comprise of 17% of the population of 8.8 million, and we have a population density of around 374 per square kilometer in comparison to the whole of Africa. Because one of the major problems in South Africa is one province, which is the biggest province, the Northern Cape, which actually hold on to the whole Kalahari Desert, and they had a population density of 1% per square kilometer. And so because of that, so we have a very low population density. But Gauteng is one of the most densely populated states in the country as well as in the whole continent. We have a literacy rate obviously better than the South African average of 92%. We have a HDI. If you look at it, in certain part of Gauteng is almost 1. And the GDP is 488 billion for the whole US dollars for the whole of Africa, the South Africa, and we had a GDP of 33% and around 10% of Africa. And if you compare with the European continents, we are equivalent of Belgium, the size of Belgian economy. Our South African economy mainly based on the service, which contributes around 33 to 40%, and which moved from last 10 years from mainly the mining-based industries to the service-based industries now. And manufacturing and agriculture plays the rest of them, because we are a net exporter of food items to the rest of the continent and outside. In Gauteng, obviously, the service industries is the main industry, and it is around 60% of the main economy comes from the service industry. And we have telecommunication and manufacturing part. In terms of the cell phone, and deliberately I put it so that you understand, we started cell phone was introduced in South Africa 14 years ago. And we had, out of 49 million people, we have 45 million cell phone in the country. And in Gauteng, where our population is 8.8 million, we have 10 million cell phones. There are very rarely you can find people who don't have any cell phones. So it actually changes us how we communicate, particularly in the health sector. And it's very, very important for us to understand that. South Africa is a diverse country, and you can see the people from, and I think besides the US, probably this is the most racially diverse country in the world. You can see the various kinds of people. And this is the Khoi and San population, which is the original inhabitants of South Africa. And when we actually in 94, when we moved from the apartheid regime to the democratic regime, there is a whole fight between who actually will be writing the various, the signs and symbols. And we had 11 official languages. So the president at that stage, President Mandela, came to an agreement that all our signs and symbols are written in the Khoi language. And that's actually, I think, is a brilliant move so that we don't have any fight between any ethnic groups. So, and we also have the cradle of humankind, where we believe the human being was born. In terms of the racial segregations, if you look at it, Gauteng has the highest number of white population outside the Western Cape province, and we have more or less racial segregations, and we also have a Khoisan population, which is not existent in Gauteng, but predominantly they're from the Northern Cape and Kalahari region. And South Africa is a diverse country. So we have forests, we have cities, we have Table Mountain in Cape Town. We have Sound City, which is equivalent of your Disney park. And we also have big forest and animals. So we are a diverse country. And if you look at it, I mean, our birth rate, which is sitting at 90, I mean, in Gauteng, it is sitting around 15, which is less than South Africa. Our death rate is 12 per 1,000 population. Our total fertility rate is 1.7 per woman. Actually, so it is going down enormously. Our infant mortality rate is 31. And this is where actually one of the problems what we have is that if you look at it, our GDP and our economy, this is unacceptably high. We spend around $32 billion US dollars in our health expenditure, and which is spread between the government and in the private sector. In Gauteng, we spend around $2 billion. In public sector, around $3 billion in the private sector. So if we talk about the burden of diseases in South Africa, and we have 4 burden of diseases, like we have various geographical regions, the deserts, the snowscape, and the ski mountain. We have the forests, and we have the beach. We also have a quadruple burden of diseases, like the pre-existing transitional diseases like tuberculosis, the emerging chronic diseases like diabetes, obesity, hypertension, and we also have injuries, and we have one of the highest burden of injuries in the world. And then we have the HIV/AIDS. And if you look at it, this is a burden of disease study, which is based on the mortality data, which was done around 2000. The HIV/AIDS is the highest burden of diseases, followed by the cardiovascular diseases. And it is same more or less in the male and female population. So if I take the NCD out, it is overall cause of death. I mean, it is the first causes of death, and it's contributing 37% of the death in the country. And HIV comes second as 30% of the death. And death rate due to in non-communicable diseases in the woman is almost 40%, and in the male is 36%. And it is also contributing significantly to years of life lost. And this increasing burden of diseases in NCD, it's threatening or already overstretched the health systems, because we have the huge burden of HIV and emerging diseases. On the top of it, this sudden increase on the NCD is also actually stretching the health systems. And it depends on how efficient our health system is. And just to give you some idea, this article came out in Lancet recently, last year. And if you look at it, the burden of diseases is gradually going up. All of them, started from stroke to diabetes, ischemic heart disease, hypertension, nephritis, all of them have started going up over the recent years. Just to give you some idea about the prevalence of the non-communicable diseases, we have hypertension of 13%, ischemic heart disease of 5%, stroke of 0.4%, hypercholesterolemia 2%, and diabetes, according to the stats, is 4.3%. Emphysema is 7.9%, and cancer 4.3%, and obesity is 60%. Now, this is one of the problems in South African health system is that we routinely collect data from all the health facilities. Now, depending on the type of diseases, the infectious diseases, legally we are bound to report. So the statistics in terms of infectious diseases is much more robust. And obviously the problem with the non-communicable diseases is that though it was supposed to be reported both from the public and private sector, but we don't have a registry where the information comes regularly. And this is where I'm going to talk about it and using some of my examples to show that these figures, which I'm showing you here, around 3 to 4%, is not really correct. So in Gauteng, the state which I come from, we started a provincial strategy and to promote the health and prevent and manage illness conditions with emphasis on poverty, lifestyle, trauma, and violence and psychosocial factors. So this is our state goal. And our challenges are understanding and responding to the needs of the poor and vulnerable groups and providing information, education, communication to the community at large, emphasizing key risk factors. And health outcomes are not commensurate with the healthcare spending. And this is one of the problems what we have, as I'm mentioning it, that the amount of money we are spending, we are not really getting a return of investment. And I always talk about it that if we are a business, and if we are running a business, we would actually fold our company long ago because our return of investment is so poor. what you are actually getting out of it. So, there is a whole issue, linked to this. Last year, the state and the university come together and set up a research unit, which is more or less, if you look at your DCRI, which is more or less the similar aim, is a collaborative venture between the province and the university to look at some of this information, particularly in the non-communicable diseases. So our aim is to provide a comprehensive research service and training in the non-communicable diseases through multidisciplinary evidence-based and translational research, thereby reducing the burden of NCD in the province and to the rest of the country. So we have goals to bring together the research and clinical experience together, because one of our problems is that we do research, but it is not translated down into the clinical practice. And what I actually mean by we have a problem of translational research. So this is one of the objectives for us, is to actually translate what we are doing, the research, into clinical practice. To provide top quality integrated facility for clinical research. To set up an information center for data mining and training of health professionals and patients. And we collect almost 600 indicators. And the question is that how much of these indicators we are really utilizing it on a day-to-day practice, either by the managers or the clinicians, to change their practice based on these evidences. And in a number of instances, we're just collecting for collecting's sake. We don't literally use this information to change our clinical practice. To set up best practice in teaching and research, and in the context of clinical care, and expedite the translation of research practice into the clinical findings. And that's very, very important, because, we are a research-based institutions. And I was just telling Dr. Baker, the current Vice Chancellor of the university has a vision that to convert this institution into research institutions and making one of the top 100 institutions. And obviously we do research, but our research is not translating into the clinical practice. And to create synergy and opportunities for cross-fertilization of ideas, and thereby encouraging exchange between the academics, public and private sector. And this is one of the problems we have, is the divide between the academic institutions and actually the clinical practice, what's happening in the field. So Gauteng is a state, and as you can see, these are a number of cities in the state. This is very densely populated with a number of cities, and these are divided into 6 regions, as I mentioned to you. And some of the objectives for us is actually to evaluate the health facility data at the for non-communicable diseases. Setting up a surveillance site for continuous monitoring and evaluation of the non-communicable diseases. And development of intervention strategy for improving the non-communicable diseases in the health facilities. And obviously, then based on it, to develop an intervention plan. And lastly, the monitoring and evaluation. And this is our focus of the center, is looking at, for the cardiovascular diseases, looking at the clinical epidemiology, the translational molecular cardiology, technological advances in CVS, and phenotyping. On the metabolic diseases, we are interested in the clinical epidemiology, the reproductive endocrinology, mechanistic and laboratory studies, and translational interventional studies and phenotyping. We believe that we should do the translational research and evidence-based healthcare, and through that we wanted to develop the research capacity. And this is more or less a structure which we are following based on the WHO stepwise approach. Looking at a situation analysis, as I mentioned to you, that we collect data, and being a collaborative center with the province, one of the advantages what we have is that we have access to the state data. And then verify it, this data which is actually routinely collected by the province, and verify it to see that how best is that the quality of the data. And then setting up some sentinel sites at the community level to see that what's happening there, and then develop an intervention, and eventually going back into the cycle and see that what is going on, whether these have any effect on it. And I think this is important for us because, we routinely, criticize our health facilities, the clinicians and the managers for not collecting good quality data. But when they come back to us and they said that, but we collect data, but what is there for us? And I think this is a challenge which we have, is to explain to them that, see that what is happening with their data, that what they do it. So we did some of the work, and I'm going to present 2 studies, which is one is a very broad horizontal studies. What I mean horizontal is that not really in-depth studies, but just looking at some basic information. And one I'll talk about a very in-depth studies in one particular area. So the changing diabetic bus is actually an unique concept. It is a truck, actually, as you can see in the back. This truck was given to us by Novo Nordisk, and using it, going into the various parts of the country and collecting data on the diabetes prevalence. And it is a mobile unit, so you can see that we can go anywhere, wherever there is a tar road. And in South Africa, there is almost everywhere there is a tar road. So we can go anywhere, and we can set up within half an hour, we can set up this unit. And actually, we can start screening patients. So talking about the diabetes, it is the 10th leading cause of death. And it contributes around 1.2% of the years of life lost, and daily around 1.1% according to the stats which we got it in 2000. Its prevalence in 2007, which from the clinic data which we got it, is around 15 per thousand or 1.5%, and in Gauteng it is 50 per thousand or 5%. And obviously you need to remember that Gauteng is an urban population, is relatively wealthy population, so it has definitely higher diseases of the lifestyle than the rest of the country. So the aim of this bus, actually, what we call the changing diabetic bus, is to measure the random blood sugar glucose of people living in 8 provinces in South Africa, to establish the association between the blood glucose and factors such as age, gender, ethnicity, and BMI, and blood pressure and the place of incidence. The reason we choose 8, and we have to exclude the Northern Cape province, because I mentioned to you for geographical reasons, because that province is huge and it was really difficult to travel from one end to another. So we decided to exclude it. It's only 1 million people stays in that province. So we have a descriptive cross-sectional study. We visited 84% of the health district in the 8 provinces, and study population was any adults which is more than 15 years of age, who live in one of the provinces in South Africa, and resident in that area for 1 year or more, and consented to participate in the study. So we collected data from the 24,000 people. So as I mentioned to you, this is we didn't have enough depth, so we didn't able to collect a lot of information, but our main idea is to understand the prevalence of diabetes. So we collected data for 24,000 people, and in Gauteng we collected around 4,000 people. So it was a huge number of people which we collected data. So if you look at the BMI, I mean, this is just to show you the graph. We are grossly an obesogenic society. So if you look at the obesity prevalence, is huge in the country, which the normal provincial data, I mean the state data, health information data showed us that we have around 50 to 60% obesity in the country. The blood glucose, I mean, if you look at it, it is showing that the Gauteng had actually relatively less blood diabetes in comparison to the rest of the population. But interestingly, the prevalence of diabetes, although relatively high, the undiagnosed diabetes in Gauteng is 12.4%. So these are the patients, when we actually screened them, we found they are not diagnosed or yet, and they have diabetes, because each of these patients who have high random blood sugar, we send them to the clinics and we collected data. So I think this is where our problem is. So now you're looking at it, almost 18% of the population have diabetes, and which is contrasting that which is telling around 5% of the population from the clinic data. So we are now, I mean, obviously the next step is to develop a sentinel surveillance and actually collect the incident data, because remember, this is a prevalence data. So it is very deceiving unless we have information on incident data to understand what is going on. So the next step, actually, what we have started doing is setting up sentinel sites in the province to collect incident data. And that's what we are planning, and we are going back again this year to collect the same information. And obviously, based on it, then we have to do some interventions. Moving on to another favorite of my subjects, which I think is another example that which normally in US it believed that osteoporosis doesn't exist in the black population. And in my clinical practice, I mean, where I worked before in the metabolic research unit, we've seen a number of people coming with a back problem. And I started developing an interest for it, and then we did the study. So this was we looked at the vertebral deformities and in the postmenopausal black woman. And this is, so far to the best of my knowledge, this is the first longitudinal study in Africa. So we assessed the bone mass in the urban population, and our inclusion criteria was that they need to stay in the urban area, it is near Johannesburg, for at least 10 years. And we looked at their prevalence of the vertebral fractures, and we also assessed number of factors to see that if there is any factors influencing their bone mineral density and the vertebral deformities. The reason we choose vertebral deformities as a de facto indicator, because obviously that's the only way you can see that where is the silent epidemic is going. So we recruited 320 subjects by random cluster sampling techniques from one area in Soweto, which is in the southwestern part of Johannesburg. And the inclusion criteria was they must be ambulatory. They shouldn't suffer from any diseases or any medication which may not directly influence the bone mineral density. And we stratified them into the 4 groups, 61 to 65, 66 to 70, 71 to 75, and 76 onwards. We deliberately choose this group because this is the time we should expect some form of a manifestation of the osteoporosis. And one of my colleagues actually looked at it, another group from 45 to 60. So the evaluation included the anthropometry examination, the height, weight, the skin fold thickness, and also through the DEXA measurements of the bone mass. We looked at both the lean mass, the bone mass, as well as the fat mass. We looked at the nutrition and lifestyle, and we looked at the biochemistry of skeletal remodeling. Now, this is, as I mentioned to you, the one I showed you before, the change in diabetic bus was a more horizontally a huge sample. This is a smaller sample, but in a much more in-depth studies. So the cross-sectional studies, I'm going to show you some of these slides from the various sites. If you look at the lumbar bone mass over the 20 years period, there is not really literally very little bone mass lost. And we actually measured from L1 to L4. But interestingly, and let me pause it here to explain to you that we don't have any data. Normally, the way we diagnose osteoporosis, based on the American data, which is the American white population and American black population, we don't have any data for South African whites or South African black population. And one of the hypotheses for us is the South African blacks are different from the Afro-American population. And so we decided to use the white American data to calculate our T-score and Z-score. So and this data is based on the T-scores of the white American population. So if I use the T-scores, so the normal population is around 30%, the 39% are osteopenic, and around 31% are osteoporotic in the lumbar vertebrae. If I use the Z-score, you can see that this is a significant number of population which is actually below their age and sex-matched control group. Because you remember T-score gives you the comparison with the young adult reference range in the same sex-matched control, because here it is the same age-matched control. And you can see this is a huge number of population which has significantly lower bone mass in comparison to their white peers, in the white American. This is a whole body bone mass, and if you look at it, they have a significant loss in bone over the 20 years. And again, showing you the same thing, the 23% of the population is normal, and around 77% are osteopenic and osteoporotic. If you look at the hip, there is a significant loss in the bone, and around 12% is osteoporotic and 40% is osteopenic. If I look at the radius, you can see the drop is more significant, and there is around 41% is osteoporotic. But if you, the issue is that here, I wanted you to remember the Anne Prentice's study in Gambia, and she showed that the Gambian population, Gambia is in West Africa, they did a comparative study between the same age control between the Gambian woman and the Cambridge woman, and they found that though they have a lower bone mass, but they're not fracturing. So there is something actually which is protecting the population. And the same applies to my population here, that they don't have any fracture. So they are severely osteoporotic, but they're not fracturing. So we looked at the various factors, and so the issue is that definitely there is a significant decline in the BMC and BMD across the 4 age groups, in hip, radius, and whole body. But there is no significant changes in the lumbar BMD, because our hypothesis is that when this started, the menopause, they already have lost some, so they didn't lose much in the lumbar vertebrae. And what we found, we did a multivariate analysis, and we found the three factors which influences the bone mass is the lean mass, the lower limb muscle strength, and the fat mass. And you remember the South African population is grossly obesogenic. So probably that is what protecting us. So we also looked at the longitudinal data, and this is the 5-year data. So we followed this individual for next 4 years and we found that they had the study collaborated the above findings except the whole body. So all the other three sides, the radius and the hip, they start losing bones. So we suggest that the difference in the bone mass are due to the fact that cortical bone is more affected by age-related changes than the trabecular bones. And probably that's the reason we see these changes happening. So if we look at vertebral deformities, the 28% of the women have lost in the cross-sectional study, around 30% have vertebral deformities. And in the longitudinal study, where we have now, this is the first incidence data which you can produce, and they lost around 20% or more decline in the vertebral height, is around 28 women, which we have the data, and that's 38% of the population. So, and we found the factors who influence the vertebral deformities is the lean mass. So give you some ideas, so there are around 80 out of the 84 people which we have the cross-sectional data, which have multiple deformities, 30% of them have number of subjects with the vertebral deformities. And if you look at it, the number of vertebral deformities, there are around 129 out of the 277 subjects. And there are number of subjects have more than one deformities. And if you look at the longitudinal data, there are around 28 out of the 74 population, which have data for all the 5 years, have 38% of them has significant vertebral deformities. So the high prevalence of vertebral deformities in the cross-sectional study and the high incidence of new deformities in the longitudinal study were unexpected but confirm another study which done a convenience sampling in Cape Town. And I think this is the first time we have started talking about, which is people never accepted that the vertebral deformities or osteoporosis is a problem in the black population. And because they were never been given a chance to provide any treatment, or even the medical aid would not cover their cost for DEXA examinations. And this is the first time actually we are now presenting the information that the osteoporosis is not a myth among the black population in South Africa. So looking at some of the factors influencing the bone mass, these are the factors we found that have a positive influence, like the BMI, lean mass, fat mass, the physical activity, and muscle strength. Calcium intake and diabetes and hypertension is no influence we found in our study. Look at this. This is the obesogenic society, as I mentioned to you, and this is a huge population which is grossly obese, and these are the elderly population. So you remember they are now almost 60 years old, so they were born in around after 1940s, and this is the population which is grossly obesogenic. And our data, recent data, shows this is worse than what we see now. In the physical activity, there is obviously a decline in the physical activity as the women are getting older. But the issue is that we found that this physical activity, if we adjust for the body weight, they decline significantly more. There is a significant decline in the muscle strength, and what we did is that we looked at muscle strength and we looked at the total lean mass, and we see there is a significant relationship between the two. We had a problem with the calcium intake, and you can see that they have a very low calcium intake, and our hypothesis is that all the South African data on the calcium intake is actually not correct, because they normally show there is a very low calcium intake, but there is a wide variation in calcium intake. This is a problem with the calcium intake data and the papers which are coming out of South Africa, and we are writing it up to say that our methodology, we need to sort it out to report the calcium intakes. We have 11% of the population is diabetic and around 47% is hypertensive. And you remember, this is a random sample. So this is the true prevalence of the general population. So in terms of the biochemistry, we have hypocalcemic. Around 8% of the population is hypoglycemic. They're relatively low 25-hydroxyvitamin D, around 46% of them, and 22% have elevated intact parathyroid hormone, and 32% have elevated alkaline phosphatase level. These alterations in calcium hemostasis are thought to be due to the relative vitamin D deficiencies. And we believe this population actually, South Africa has a lot of sunlight, so we don't understand that why this population is relatively low vitamin D deficiency. And probably there is a low dietary calcium intake, because most of the studies report the calcium intake around between 400 to 800 milligram per day. So our key findings suggested that the magnitude of the problem of low bone mass and vertebral deformities in the postmenopausal black South African woman. And I think this is a study which I mentioned earlier in my topic is on silent epidemic. So if there is around 30 to 40% of the population have some diseases, for me, I believe this is an epidemic. And the importance of lean mass, the lower lean muscle strength, and fat mass in maintaining bone mass. And I think this is an area which we need to look into it if we want to develop some intervention strategies. So what is the way forward? And obviously, when I presented this study to the Department of Health, they were shocked, because this is the debate we started having it to convince our policymakers and our health facility managers to provide some of the issues. That how do we challenge our health systems so that it become tuned with the evidences which we are producing through our research. So the high burden of NCD in South Africa is now acknowledged by this study and a number of studies done by my colleagues. The accurate information is not always available. You remember, I showed you the health information data is showing there when there is a prevalence of around 5%, and we are showing around 15% of the diabetes population. Where there is a non-existence of the osteoporosis and the low bone mass, we are showing this is a significantly number of population has the osteoporosis or vertebral deformities. And as a result of that, our budgetary allocation for not based on the burden of NCD. So there is a measured allocation to the non-communicable disease budget allocation. And the research done in this area is not translated into practice. So we don't practice what actually the research we are doing. And interventions which we do is not evidence-based. So what we believe is that we need to have an integrated approach to the healthcare based on the optimal utilization on available resources to reduce the burden of diseases. Because we believe that there needs to be some link between the resource allocation of the managing the diseases so that we can actually, based on the evidences, where we can allocate the resources according to that. And this approach requires the use of evidence-based healthcare. So it shouldn't be arbitrary. It should be based on the translational research. So the research what I'm showing you is actually we need to take it, translate it into our practice. Like now, after we showed it, so anybody who is coming with a back pain, we are now doing the exam. Economic analysis is important because we need to see the return of investment. So that if we are investing on the healthcare, we need to see the return of investment is coming out so that we are seeing better health outcomes. And we need a close collaboration among the various role players, particularly between the health professionals and the health managers, so that what we are doing research on, we need to present it to our Department of Health colleagues, the policymakers and the managers, so that they understand the burden of disease is changing from an emerging infectious diseases to a dual burden of diseases or quadruple burden of diseases. And this came from the Bigelhol, and Bigelhol talking about there is a need from our clinical approach that where we see individuals to a healthcare organization-based approach based on better clinical outcome for chronic disorders. And we looked at it so that we looked at the prevention strategies from the primordial, primary, secondary, and tertiary cares, preventions. We need to look at the care also on the other side as primary, secondary, and tertiary cares so that we have better health outcome for the chronic disorders. And we believe that we can make this right turn possible. Thank you.
So Deb, one of the things that we've been talking about is collecting more information, obviously, that's near and dear to our heart. You seem to be not doing random epidemiologic surveys to get the health data information. What data are available from the provider side? How many hospitals are there in Gauteng? And 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 how would they link together to provide information? So if we wanted to do, say, the cardiovascular registry across the province, how would that work?
As I mentioned to you, that it is there are two sets of information which normally comes. One, every health facilities are obliged to provide the information on the diseases which they see on a monthly basis to the health district, to the province, and then it collated at the national level, and we get data based on that. On the side of it, we also have the data for the notifiable diseases which follow another track. So obviously, we can verify the information for the infectious diseases because we have two sources of data and we can verify to see that what's going on. Problem with the non-communicable diseases is the data comes routinely from every health facilities, but as I showed you, that the study, the reason I showed you those two studies is to show that this is not, the quality of this data is not good.
Right.
So the infrastructure is there, but obviously to understand it and translate into it so that it become a data which is of good quality, which can be used then for practices, and that's where the challenge is. So when we establish a registry, we don't need to start from the scratch. What we need is to actually translate this information and strengthen this health information system so that it can be good quality data.
Yeah, in the U.S. for many years, our data were things that you didn't get paid for weren't coded very well, and that kind of continues to be there. I remember looking at Kaiser's data one time, and the most frequent diagnosis was not recorded. That was a separate category, and that was like 70% of visits. So is there any reason why for the non-communicable diseases people would actually report, other than, why physicians would chart it? Does the hospital have a way of keeping a record of that? And do they get paid separately or differently if they provide that data to the government?
I don't think so. I mean, it's just a question that is a question of legality issue. So if I see a patient with tuberculosis and I don't notify, in terms of the legal system, I lose my registration as a medical practitioner. So it's mandatory. If I don't report a diabetic patient, I would not lose my registration. So question is that, so if I see 100 patients, 100 TB patients and 100 diabetic patients, I think that they don't actually capture it in that way. And I think this is one problem. So the legality, legal framework is quite important. The second issue, is a question of the diagnostic testing. Because it's easy. So when we have diagnosed TB or the measles, we know that the person has tuberculosis, the bacilli, or the measles, and we can definitely diagnose the patient. Now, how do you diagnose the person has obesity or the person has definitely the diabetes? And there is a whole set of diagnostic criteria which we need to use. So obviously one of the changes which we have started introducing for the last couple of years is instead of writing the diagnosis, we now made it compulsory that you have to fill up the ICD-10 codes. And so like the prescription, the pharmacy will not issue a prescription and medical aid will not pay unless you have an ICD-10 code. So in a way, so that actually forces the clinicians to reach a confirmed diagnosis. So you cannot just leave your diagnosis blank. And I think that improved our reporting system because now there is always an ICD-10 code. And I think this has cleared up the diagnosis and also actually helping for reporting. So somebody is reporting diabetes mellitus type 2 and somebody is reporting non-insulin dependent diabetes mellitus. Obviously, if he's capturing it, it's difficult for that person to capture. But when we are using the ICD-10 code, it becomes uniform. So I think we have started looking at it the various ways to improve the reporting system.
Let's open this up for questions or comments, suggestions. People want to take a vacation. I'll hang for a microphone.
I'd be interested to hear how you communicate with health officials in the government, because obviously there's going to be a communicable disease. There's a much higher concern about that because it is communicable. I mean, what justification do you give to the health authorities that this is important when it's not sort of immediately dangerous?
And I think this is the biggest problem, is that, we are talking about the health promotion of the community, and I think we need more health promotion about health policymakers and the politicians. because for them this is not really sexy or attractive to invest on the non-communicable diseases. Luckily, the government now started understanding, because through the various research, the burden of disease studies, through my work, and through our unit's work, and we started getting a political attention, and that this is a serious issue. It is challenging. So we are still struggling to make them understand it's much more attractive to invest on HIV and it's more politically correct than to invest on diabetes management. So it's not easy. I think it's a long struggle, but obviously we started the struggle, and hopefully we'll overcome it. Mike?
Yeah, I just wondered how all this was funded.
Sorry?
I just wondered how all this was supported. What was the funding source, and how did you get all the studies done? There's a lot of survey work here.
One of the things which we are lucky, most of the surveys which we've done, it is internal funding from the province. Because there is a significant fund allocated within the province for research. And so our unit, what we do is that we don't really look for specific funding for the project. We try to utilize the existing stuff. Like, for example, when we did this work on the changing diabetic bus, we actually used the provincial staff to go into as the researchers to go and collect the data in each of the provinces. The laboratory testing is absorbed by the provincial government. So it literally doesn't cost us. The money gets absorbed by the province and the university. So the funding for most of the funding usually comes from either the province or through the university through its research fund. Obviously, and that's the reason it is sustainable in comparison to the other projects. Obviously, in certain instances, we need some seed funding to start the projects. And that's where I think the major challenge is that, like where we started, like this study which we have done, we got initial funding from the MRC, the osteoporosis study, to start the project. Obviously now it is get absorbed by the province and the university, which is now taken over, and they're providing like routine DEXA testing, bone density measurements for all the women who are coming for the back pains.
It's not in your slides, but can you talk a little bit about the hospital management work that you're doing? One of the things we chatted about is how does this idea of process improvement and quality information become part and parcel of what we train people, or how we train people to run hospitals? So who's coming to you? What's the relationship with the government, and what are your challenges on that side?
I think you need to forgive me because when I start preparing this presentation, I have almost 80 slides, and I got 40 minutes. No. So obviously, I had to cut those slides and take it out and just show you some justification of like a part one to show you the problem. So basically, the part two of the problem is the answer to it. So what we started doing it, like I'm doing this presentation to you, I'm doing this presentation to the health policymakers, to the hospital managers, to make them understand that why they need to collect this information. Because every time we are, asking the hospital CEOs or the hospital managers that please collect the information on diabetes. But they don't understand that why. And now we are showing that why, the loop, and actually we are coming to it. And I'm going to use another example so that, though I didn't talk about it, and one of the problem, like we are facing is the insulin resistance. And because you see that we have a huge burden of diabetes, so we started getting a number of insulin resistance patients which is coming to us. And we have insulin analogs which is available. And the hospital where I work, the CEO refused to provide the insulin analogs for the patients because it is not in the state list and they will not provide it. And we did a small study to justify the cost effectiveness of providing insulin analog to the patients in comparison to actually prevent the complications. And as a result of that, we actually managed to put insulin analog into the state list. And now insulin analog is routinely available to the state patient. And I think this is a type of work which actually show from completely clinical work, moving into the non-clinical domain, into the management domain, where people started practicing medicine, practicing management based on evidence, which actually showing the outcome-based work. And I think this is important because for him, he sees insulin analog is costing 10 times more than insulin. But when he sees the cost actually is cheaper to provide insulin analog because it reduces the complications, then it becomes attractive to him. And I think this is overlapping between the management and the clinicians, and I think very, very important, and the dialogue actually. And I don't think that it is easy because we have trained in different ways, because I was trained as a clinician, and my job is to train and teach individual patients. I don't really care about what happened to the rest of the country, rest of the individuals, whereas a manager is trained to manage the whole health systems. And I think there is a dichotomous situation, and it's not very easy to put these two conflicting views into one area and actually started understanding it. And I think this is where we started training in our program, as Kevin mentioned about the hospital management program, is I bring a clinician, I started training and make them appreciate that why it is important to collect information on diabetes or tuberculosis, because that helps you to practice better management.
Great. Any more questions? Any other questions? Well, Deb, thanks so much for joining us today, and thanks for visiting us here at Duke.